According to the Heart and Stroke Foundation's 2018 Heart Report, 5 times as many women in Canada die from heart disease as from breast cancer. The fact that that will come as a surprise to many people may point to part of the problem. Joining us now to get a better handle on this in the nation's capital, Dr. Thais Coutinho. She is chair of the Canadian Women's Heart Health Centre and chief of the Division of Cardiac Prevention and Rehabilitation at the University of Ottawa Heart Institute. And here in our studio, Dr. Paula Harvey, physician-in-chief in the Department of Medicine and director of Cardiovascular Research at Women's College Hospital, and Sherry Grace, senior scientist with the University Health Network and a professor at York University. And we're delighted to welcome you two here in our studio and Dr. Coutinho in Ottawa to our program tonight. Let me just share this excerpt from the Heart and Stroke Foundation's Heart Report, and this will get us off to the races. Sheldon, thank you. The leading cause of premature death for women is heart disease. 2 out of 3 clinical research studies on heart disease focus on men. Most women miss the early signs of a heart attack, which can last weeks or even months. And when women have a heart attack, they are more likely to die from it or to have a second heart attack in comparison to men. Let's get into this. Thais, why are heart attacks deadlier for women than for men? Let's start there.
Might as well start with the million-dollar question, right? I think if we all know the one answer to this, we wouldn't be here talking today. We would have solved that problem. But no, joking aside, it's probably a multifactorial issue. You already mentioned yourself that 2/3 of research in cardiovascular disease have focused on men. So a lot of what we know about clinical manifestations and what works and what doesn't work, it's really very applicable for men, not necessarily applicable for women. In addition to that, there's also a matter of pattern recognition. The symptoms that we learn as healthcare providers, in school as we're studying to find out what does a heart attack look like. And sometimes what the women too in the community, what they hear about what the symptoms should be for when they're having a heart attack. Well, those descriptions were made based on men. So sometimes women present in different ways, and it makes it harder for the woman to recognize she's having a heart attack. It makes it difficult for the provider to recognize it, and that coupled with the lack of robust scientific data to support the diagnostic and therapeutic effects, I think all of this put together has helped lead to the higher death rates after a heart attack for women than men.
Well, Paula, let me ask you the obvious follow-up question, which is, if this is such a stark situation for women, why would 2/3 of the studies and testing be focused on men?
Well, believe it or not, that's actually a significant improvement, Steve, from a few decades ago when I started in the area of women's cardiovascular disease. One of the major issues when you're doing research, whether you're doing research in animals or research in humans, is that first you have to identify that there's a problem. So we needed to identify that women actually had heart attacks and had heart disease, not just men. Secondly, doing tests in women, in human subjects, can be complicated because of a number of factors. Firstly, women are at risk of getting pregnant, and there are concerns about safety to the woman and a fetus if you have somebody in a clinical trial. And that's made people very wary about including women into clinical trials.
And that takes a whole bunch of people out of the mix right away.
Right, yeah. And we're, the funding bodies are actually addressing that and making sure that women can be safely included in clinical trials in their reproductive years. And secondly, women have this complication of what we call sex hormones. So we have a reproductive lifespan where our biology changes in different phases of our life. So there's premenopause, there's postmenopause, there's pregnancy, there's post-pregnancy. And that's another layer that needs to be incorporated into the clinical trial. So even when if you're doing your studies in animals, it means you have to take into consideration the biological differences between male and female animals. So to incorporate the female animals, which are more complex and more difficult, it makes you have to be aware, and then you have to make sure that you have the funding and that you have designed your trial that way and you do the appropriate analyses.
But given the way you've described it, is it too big a challenge to hope for the day when it's more 50-50?
No, I don't think so. I think there's a huge groundswell. This is a great time for us to be talking about women and heart disease. It really fits in very well with awareness across society, not just healthcare, about sex, gender, equity. And there are strategies where this can be incorporated into research. So if you're looking at some of the funding bodies like CIHR, Heart and Stroke, they are...
Canadian Institute for Health Research.
I should, for the acronym. So it's one of the biggest research funding bodies for health research. They require, when somebody puts in a grant application for a research study, that they incorporate sex and gender into the study protocol and into the analysis.
Okay.
And other funding bodies are following suit.
Sherry, I think you said in the Heart and Stroke report that doctors generally don't refer women to rehab as often as men after women have a heart attack.
Right.
Why is that?
Yes, it's very interesting. So rehab programs are kind of these chronic disease management models. So patients and women come in and see us a couple of times a week over a few months. And yeah, women are less likely to come into our doors and they're less likely to stay once we do get through the doors. I think it can be, again, it's multifactorial. So we have shown that there's bias on the part of providers. It's often unconscious. But, you know, women too might be saying things to their physicians, things like, you know, I can't get there because I don't have transportation, or I have family caregiving responsibilities, so I can't make it there. So there's kind of societal and logistic factors as well at play.
Is that why women have second heart attacks? Because they don't necessarily get the rehab they need after the first.
Right, exactly. So, you know, women who've had a heart attack definitely should be coming, and those who do come to rehab have about 20% lower chances of having another heart attack, of having another hospitalization, needing a heart procedure. So exactly, if we don't get them into the door, we're not going to get that benefit accrued.
This issue in the differential in the way men are tested versus women, many more men as a percentage of tests, does this go across specialties, or is this specific to the heart?
I can't speak with complete authority, but I would say that this is going to be across all the specialties, where because of the complexity of including women in your research and female versus male animals in the research, I think this is actually a problem that's common to all of the subspecialties, and believe it or not, cardiovascular disease is somewhat ahead of the game when it comes to looking at sex and gender differences.
So maybe 2/3, 1/3, but it's still better than others.
In some ways, yeah.
Okay. Thais, let me follow up on one of the angles we just heard there, and that is, how can physicians check their own biases at the door to make sure that they are serving their female patients appropriately?
It's a great question as well. Actually, there are tests that one can take about unconscious bias for many aspects of healthcare. Actually, I would encourage anybody watching to take them, because even the ones of us who believe that we are very unbiased, we actually end up learning that we still have some bias even in some areas. And then once you're aware of that bias, then of course you reflect upon that, and it may change the way that you practice. So that actually there are standardized testing that people can take to realize and reflect upon that.
Now let me draw an inference here, and you tell me if it's correct. You're a female cardiologist. Does that mean that you are less likely to have a bias against female patients than, say, a male cardiologist?
Well, you're not only talking to a female cardiologist, but you're also talking to a female cardiologist who runs a women heart health program. So I'm very biased in the other direction, I think, you know, me as a person, because I'm so well aware. I mean, we just ran this national summit about women and heart disease. So of course, we're preaching to the converted here. So in that sense, I would think that my bias for that specific subject is lower than usual. But if you actually look across the community, there are still lots of female providers who may have an unconscious bias simply because we all learn from the same books, right? We all learn what heart disease looks like from the same books and, you know, from similar mentors. So the bias still exists in men and women.
Interesting. Sherry, let's take Thais out of the equation, because we know that her mission in life is to turn the bias in the other direction. In your studies and in your experience, does that bias exist more in men than it does in female cardiologists?
Yeah, it does. So we did a study where we presented physicians in Ontario, rural, urban physicians, family physicians, and specialists with different scenarios of heart patients, and we kind of randomly, by the flip of a coin, presented men versus women. And we asked the physicians to rate, you know, how likely are you to refer this patient? How much do you think they'll benefit from them? And we also timed the speed with which they did the ratings. And so so we were able to show that indeed that there is much unconscious gender bias still, and also that about 2/3 of the physicians weren't aware that they were biased still to this day here in Ontario.
So what do you want to do about that?
Right, so I think as Thais mentioned that there are some strategies around education to increase awareness among healthcare providers.
But that's good if you're coming, I mean, if you're in med school now, that'll be helpful. What about the people who've been practicing for 25 years?
Right, so we need to do continuing medical education. We need to increase awareness by shows like this and being here today. And I think women themselves need to be aware that, you know, say you have a heart problem and you're having chest pain and you're also having sweating and nausea and indigestion, when you get to the emergency department, say I have chest pain, because then they will initiate the chest pain protocol around getting an ECG and getting that diagnosis so that you get treatment really quickly and you have less heart damage. So again, women kind of advocating for themselves and being aware that they need to go to rehab and what tests and treatments they need.
Gotcha. Thais, how different physically is the female heart from the male heart?
From a very simple perspective, you know, female hearts are smaller, the arteries are smaller, you know, we are smaller people in general compared to men. But outside of this gross anatomical differences, there are actually many things that are very similar between the two people. But I think what differs is beyond just the visual inspection, is sometimes the types of disease that one heart may be more predisposed to than the other, for example, or the way in which women perceive the symptoms, perceive the signs of a heart disease compared to a man. So there are some anatomical differences, but even beyond that, a lot of differences in terms of disease predisposition and interpretation of disease signs and symptoms.
Okay, Paula, let me follow up with this. The sort of typical image we have in our mind of somebody having a heart attack, right? Somebody who feels that pain going up the left arm, grabs their chest, and maybe collapses.
Right.
When we think of that, it's almost always, I think, a man we think of doing that. Do women experience it the same way?
So that's what we call the Hollywood heart attack.
Because it really doesn't happen that way?
Well, no, it does. But one of the things that Thais was just touching on there is that the studies have shown that women and men do present with chest discomfort, but men are more likely to call it pain, and women have a different way of describing their symptoms. So it may be where a man says he's got terrible pain, a woman may say she's got pressure, or some sort of squeezing, or a knife-like pain in her chest. So it's different in the way that they present, and then they are probably more likely to have these other symptoms like sweating and nausea and feeling like they're going to pass out. So it's part of it is the way that women present, and we used to refer to women as having atypical symptoms because they didn't have the Hollywood heart attack. But if 50% of the population is women, why would that be atypical? So what we're actually referring to now is female pattern of symptoms and female pattern of chest pain rather than atypical symptoms.
Does that include the pain in the left arm?
It can include pain in the left arm. It can include pain in the jaw.
In the jaw?
Yeah, yeah. Anything actually above the umbilicus is fair game. Up into the earlobes is fair game for pain from the heart.
Okay, forgive me. Umbilicus?
Sorry, the belly button.
So
anywhere from here,
where the umbilical cord was.
So anywhere from middle of your waist up to your ears, you can actually experience discomfort in relation to a heart attack.
Sherry, why is it that the sort of best well-known symptoms seem to relate to men as opposed to women?
Yeah, I think as we've alluded to, that it's typically been thought of as a man's disease, and we thought more men had heart disease than women, but it's not the case. There are equal number of cases in Canada of heart disease in women and men. So just by a function of raw numbers now, we need to recognize that women and men are both likely to have heart disease.
But I guess what I'm fishing for here is whether men tend to be the storytellers of heart disease, and therefore, when we think heart disease, we think men, thereby ignoring half the population.
Right, and I think women often think breast cancer. They are 5 times more likely to die of heart disease than breast cancer, but they'll be concerned about getting, breast screening, and it's just a shame because we know that they're much more likely to die of heart disease.
Well, in which case, we better leave some advice for people this evening. And Thais, I want to get you in here first. What can women do to prevent heart health disease?
It's a great question because we know that 80% of cardiovascular disease can be prevented, and that goes for men and women. So the advice I would give to women that are watching is, first of all, if you've never had heart disease, just know what the risk factors are and know what your individual risk is. So the way to do that is you can go to reliable websites, and I'll give an example. If you go to yourheart.ca, you're going to get to our Women's Heart Health Center's website, and you can link to our database, to our library, and also to our virtual care program, and have that assessment yourself. Or you can talk to your family doctor, your cardiologist, and get your risk factor assessment. Know what your risk is, because the example I like to give is, if I'm driving a car and I don't even know that getting into a car crash is a possibility for me, I'm not going to buckle my seatbelt, right? So that's why we say, a woman has to know, am I at risk? And what are my risk factors, so they can work with their providers to really enhance their cardiovascular risk factors and really prevent disease. We actually got a very good message from Dr. Sonia Anand, who was the keynote speaker for our summit this past week. And she told us that if a person, men or women, has no cardiovascular risk factors before the age of 50, the risk of them having cardiovascular disease in their lifetime from that point on is only 5%. So, it's a good message here for prevention. Now, for women who are out there who have already had heart disease, it's very important that they take ownership of their health. And not only do they monitor their risk factors going forward, of course, to prevent additional events in situations when it can be prevented, but also to know what causes it, what symptoms, how to advocate for your own health, really take ownership and put themselves first. As women, we are very good at putting, everybody else ahead of us, but in situations like this, when it's so important to take care of our hearts, we have to remind women to always put themselves first when it comes to their own health.
And I would maybe add, Steve, as well, that there are certain risk factors that are actually more hazardous in women than men if they have them. So, for example, smoking. So if you have 10 men that smoke and 10 women that smoke, more of women will develop heart disease than will men. Similar situation with high blood sugars or diabetes. And also with depression. Depression is kind of an undervalued or underknown, underaware symptom of heart disease, and women have 2 times the rates of mental health issues such as depression and anxiety as men, and it's really implicated in both the development of heart disease and also prognosis.
At what age, Paula, roughly, age range, are you most vulnerable as a woman to suffering a heart attack or dealing with heart disease?
Well, there's sort of 2 times in our life when we're particularly at risk. So to begin with, we know that older women are at risk of heart disease. Usually they're at risk.
Define older.
So someone who's postmenopausal, and usually the woman in the second part of her life is likely to develop heart disease 10 years later than a man, and that's problematic because then they often have other conditions as well, what we call comorbidities, that can make the management of their heart disease more difficult and more complicated. So there's the second half of our life, particularly older, so over 60, 65. And then there's in the premenopausal phase, we have to remember that pregnancy is like a stress test. And women going through a pregnancy, they are at increased risk of things like pregnancy-induced hypertension and pregnancy-induced diabetes and some pregnancy-related complications at the time. And we know that if they develop those problems in pregnancy, they're 2 times as likely to develop heart disease in later life. So we need to be aware of what's happening
Let me just understand that. Can pregnancy create new underlying issues leading to heart disease?
There are other, not related to the sort of heart attacks that we're talking about, but there are pregnancy-specific issues and that can affect the heart, but also these effects on blood sugar and high blood pressure, which really we are learning a lot now about these being specific risk factors for heart disease in women going forward. And women need to understand that, and their healthcare providers need to understand that.
We've got a little more than a minute left to go here, Sherry, and I have to confess, I know lots of men who've had heart bypass surgery. I don't think I know any women at all who've ever had it. Is that typical?
So certainly women are being treated less aggressively. They're less likely to be treated by a specialist. They're less likely to get the medications that they should be on, and their procedures that they get are less aggressive as well. And they often have more adverse outcomes from stents and bypass surgery and some of the medications that we put them on. So we really need to know how to treat women specifically and what these treatments, how they impact women differently than men through our research studies.
And is that happening?
It is. It is now happening in Canada, and I think we're doing actually a really nice job in leading globally in that regard.
So when we have this conversation again in 10 years, you're going to be able to say things are so much better now that we're so much more aware.
Yes, and we're saving many more women's lives.
Okay, good to know. That's our time, everybody. Thank you so much for this. Absolutely revealing. Thais Coutinho, cardiologist, University of Ottawa's Heart Institute. Sherry Grace, University Health Network and York University. Paula Harvey, physician-in-chief, Department of Medicine, Women's College Hospital. Great to have you all on TVO tonight. Thank you very much.
Thanks, Steve.
Thank you, Steve.
The Agenda with Steve Bacon is brought to you by the Chartered Professional Accountants of Ontario, helping businesses stay on the right side of change with strategic thinking, insightful decisions, and business leadership. Are you on the right side of change? Ask an Ontario CPA.